Good afternoon, esteemed members of the jury, distinguished guests. My name is Chettibi Ines. I'm a second-year resident at the Department of Nuclear Medicine of Annaba. Today, I'm honored to present my work entitled High Scores, Quiet Bones, Rethinking Risk in Prostate Cancer. My presentation would be structured as follows. First, a brief background on prostate cancer. Then I would discuss the impact of bone scan on the management of prostate cancer, so I can after present in detail my study. Starting with some statistics, prostate cancer is the most common urological cancer in men worldwide, second leading cause of cancer-related death in men. More than 2,000 new cases have been reported in Algeria since early 2025, making it for sure a huge public health challenge. Histopathology, the most important thing to highlight in here for us is that bones are the most common site for metastases from prostate cancer. Once in bones, prostate cancer cells disturb the normal bone remodeling, shifting the balance toward excessive bone formation. That's why prostate cancer metastases are often osteoblastic. Once injected, the coupled technetium MDP will bind to hydroxyapatite crystals through a process called chemosorption at sites of active bone remodeling, including those of metastases. A quick look on a crucial anatomical structure called the Baston's plexus. It's a network of valvulus veins allowing a bidirectional blood flow. It connects the venous system of the prostate with an internal vertebral veins, helping with the dissemination of prostate cancer cells to the skeleton. It's also important to mention that PSA can be elevated in several conditions other than prostate cancer, such as urinary infections, so we can easily say that PSA is characteristic of prostatic epithelium and not of prostate cancer. According to D'Amico classification, high-risk patients are those with a PSA level higher than 20 nanogram per milliliter or a Gleason score greater than or equal to 8. These high-risk features are among the main indications for bone scan according to the guidelines of the French Association of Urology. According to the same association, the impact of bone scan on the treatment strategy is up to 15%, 11% of which are major changes from curative to palliative strategy. This slide shows the several levels of implication of bone scan in the management of prostate cancer. Another important impact of bone scan, but now on the survival rate. While the 5-year survival rate for local and regional prostate cancer is nearly 100%, it decreases dramatically to 37% for metastatic prostate cancer. Now, versus PET-CT, as a part of prospective study, prostate cancer patients underwent both a PSMA PET-CT and a bone scan at the Department of Nuclear Medicine of Turin. The results were that PSMA PET-CT led to a TNM upstaging in 45% of cases. Another retrospective study that included prostate cancer patients who received both bone scan and PSMA PET-CT within 3 months showed the well-known superiority of PET-CT. At this point, we may think that it's so obvious and easy to say that PET-CT is much better than bone scan. But on the other hand, we should not forget that bone scan is more available, less expensive, lower radiation dose, and decades of clinical use. That's why, till this day, bone scan remains the conventional imaging modality to detect skeletal metastases in prostate cancer patients. So overall, we have a very common cancer with high morbidity, high mortality, that is highly osteophilic, mostly osteoblastic, with well-established but standardized indications of bone scan in high-risk patients. On the other hand, we have a conventional imaging modality that has a huge impact on both treatment strategy and the survival rate. So our study aimed to evaluate the correlation between high PSA levels, high Gleason scores, and the absence of metastases on bone scans in high-risk prostate cancer patients. We performed a retrospective study that included newly diagnosed prostate cancer patients referring to Nuclear Medicine Department of Annaba from January 2022 to May 2025. 100 patients met the predefined criteria of inclusion with a mean age of 70.7 years. The study included 2 major groups of PSA levels and Gleason scores divided according to the D'Amico classification. For each group, we evaluated the results of bone scans. Bone scans were performed in our department using MDP labeled with technetium-99 metastable, administered intravenously at a dose ranging from 8 to 20 millicurie. A whole body planar imaging and SPECT-CT acquisitions were performed 2 hours post-injection using a hybrid head dual gamma camera equipped with low-energy, high-resolution collimators. So this study validated the positive correlation between raising PSA levels, increasing Gleason scores, and positive bone scans. We can clearly see that as the PSA levels and Gleason scores increase, the proportion of positive bone scans increases as well. But it also revealed an unexpected significant proportion of negative bone scans among high-risk prostate cancer patients. Patients with PSA levels higher than 20 had an identical rate of positive and negative bone scans, which makes us question the relevance of bone scan indication in here. And even if patients with Gleason scores greater than or equal to 8 had a slightly higher rate of positive bone scan, a significant proportion still had negative results. The subdivision of high-risk patients into 2 additional ranges with a higher PSA cutoff, 60 instead of 20, helped find more significant difference. Patients with PSA levels between 20 and 60 have now a significant higher rate of negative bone scans, while patients with a PSA level higher than 60 have a significant higher rate of positive bone scans. At this stage of our study, we encountered an interesting paradox. This retrospective study talked about an 80-year-old high-risk patient who had a bone scan with no MDP-avid bone lesions, but a PET scan done 3 weeks earlier showed innumerable PSMA-avid skeletal metastases. So sometimes silence is not always absence. So, despite the well-established association between high PSA levels, aggressive Gleason scores, and metastatic bone scans, our study also revealed a significant proportion of negative bone scans in high-risk prostate cancer patients. Patients with PSA levels higher than 60 showed a higher association with bone metastases compared to those with PSA levels above the conventional cutoff, 20 nanograms per milliliter. To conclude, these findings may challenge the conventional expectations that high-risk features often align with bone metastases, maybe suggest a higher PSA cutoff, 60 nanograms per milliliter instead of 20, but they may also raise some key questions, like the potential limitation of bone scan in detecting early or indolent bone metastases, highlighting the need for further studies investigating false negative bone scans using more sensitive and specific imaging modalities, above all PSMA PET-CT. And thank you for your attention.